Welcome to this deep dive, tailored specifically for you, all you orthopedic residents out there getting ready for those postgraduate exams, FRCS, or equivalent fellowship exams. You know what I'm talking about.
Yeah, big ones.
This deep dive is based on the OrthoMade's simple notes from the website mokyingren.sg. These notes were compiled by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he finished his FRCS in 2022. So today we'll be focusing on two really interconnected topics you're going to see on your exams: fracture-related infections and bone loss management after trauma.
Yeah, bread and butter orthopedic.
Exactly. You really got to understand the ins and outs of diagnosing and treating FRI, especially how it differs from those prosthetic joint infections.
Right, because the treatment algorithm is so different.
And then when you have significant bone loss after trauma, you need to think strategically about how to manage it. There are tons of different techniques out there.
Yeah, a whole toolbox full.
So our mission in this deep dive is to break down those key principles for FRI diagnosis and management, and then we'll move on to explore those different surgical strategies for tackling those tricky, critical bone defects. We want to make sure you're well equipped with the knowledge you need to ace your exams. This deep dive is based on the OrthoMade simple notes from website mokyingren.sg.
So let's jump right in and start with how we go about diagnosing a fracture-related infection.
All right, so first things first. We need to talk about the Maker consensus paper from back in 2017. I think anyone prepping for their fellowship exams needs to be familiar with this.
Definitely a landmark paper.
Yeah, it laid out the criteria for diagnosing FRI. We've got those confirmatory signs and the suggestive criteria. Those confirmatory signs are pretty straightforward. You see those, or you're dealing with an infection.
Yeah, they're kind of your slam dunk criteria.
Things like a sinus tract, a fistula, or if you have purulent drainage coming from the wound, those are pretty clear cut.
Yeah, those are your obvious signs, but sometimes the clinical presentation isn't that straightforward.
Right, so that's where the suggestive criteria become really important.
Exactly. So you're thinking about clinical findings like pain, that's just way out of proportion to what you'd expect for this stage of healing.
The patient is just screaming in pain.
Yeah, or maybe there's persistent redness or swelling around the fracture site.
That warmth, too, localized warmth.
You can't miss it.
Huh.
Then on those radiographs, you might see periosteel reaction.
Which is essentially new bone formation in response to all that irritation going on.
Right, or even loosening of any hardware that's been implanted.
And I guess if you have a joint near the fracture and suddenly you've got a new effusion, well,
That's another red flag.
absolutely. And of course, don't forget about those inflammatory markers, those blood tests.
CRP-ESR, those are your go-tos.
They're not specific to infection, but man, when they're elevated.
It definitely makes you think twice.
Oh, yeah, for sure. And even if the wound drainage isn't obviously pus, if it's persistent.
That's another clue that something might be brewing.
So beyond that physical exam, what are the other investigations we should be ordering?
Well, you've already touched on the blood tests. Checking those inflammatory markers is crucial.
You gotta get those.
And then imaging is absolutely key.
Yeah, I gotta see what's going on in there.
You always start with plain radiographs, just to get a basic idea of the fracture alignment, how it's healing, and whether the implant is stable.
Good old x-rays.
But the CT scan, that's where you get the real detail.
Yeah, that's your moneymaker.
It helps you definitively rule in or rule out a non-union, which is often a big sign of underlying infection.
And you get a much better look at the overall stability of the fracture.
So much more information.
Now, for our listeners out there gearing up for their fellowship exams, let's talk about a really important distinction. How is an FRI fundamentally different from a prosthetic joint infection or a PJI?
Yeah, that's a classic exam question.
Yeah.
They seem similar on the surface, but there's a key difference.
I'm all ears.
It all comes down to the bone's ability to heal. In a PJI, your main goal is to completely wipe out that infection before you even think about doing a revision arthroplasty.
Gotta get rid of every last bug.
But with an FRI, you're dealing with a fracture that, if you're lucky, can actually heal. So you might be able to keep that fixation device in place.
Be it a plate, a nail, an external fixator.
Yep, whatever you're using.
You might even be able to remove it completely once the bone has fused and the infection is under control.
That's the beauty of it.
So getting rid of the infection is definitely important, but it might not be your top priority right away.
Not if you can maintain that stability and let the bone do its thing. This deep dive is based on the OrthoMade simple notes from website mokyingren.sg.
So it's all about that healing potential.
Exactly.
Now, it seems like the timing of the infection also plays a big role in how we manage these cases.
Absolutely. The timing is everything because it often correlates with how much that biofilm has developed on the implant and in the surrounding tissues.
Biofilm, that's the enemy, isn't it?
It really is. That's why we categorize FRI based on when it shows up relative to the initial injury or surgery.
So we've got early infections, delayed infections, and late infections.
Right, early is within the first 2 weeks.
Then delayed infections are between 2 and 10 weeks.
And anything after 10 weeks, it's a late infection.
Why is this biofilm such a big deal?
Well, that biofilm acts like a shield, protecting those bacteria from antibiotics.
So those antibiotics can't penetrate and do their job.
Exactly. So the stage of that biofilm really dictates how aggressive we need to be surgically and whether we can rely on antibiotics alone.
So it's not just a matter of time, but also how mature that biofilm is?
Right on.
Okay, so we've talked about the timeline. What other factors should we be thinking about when we're faced with a potential FRI?
Well, you've got to assess that fracture stability carefully
Make sure it's not wobbling around.
and look for any signs of callus formation. That's where that CT scan really comes in handy.
Gives you that detailed view.
And don't forget about the soft tissues.
Hmm.
That skin coverage is super important, especially if you're dealing with an open fracture or significant soft tissue damage.
Because that just increases the risk of infection.
Massively.
And then, of course, you've got to think about the patient themselves.
Yeah, those host factors.
Are they immunocompromised because of other medical conditions or medications?
That can make a huge difference in their ability to fight off infection,
And do they have any comorbidities that could complicate things?
like diabetes or peripheral vascular disease.
Things that could affect healing or their ability to tolerate multiple surgeries.
Absolutely. And finally, don't underestimate the bacteria itself.
Different bugs have different personalities.
Some are just more aggressive than others.
So with all of that in mind, what's the main goal when we're managing an FRI?
Well, the ultimate goal is to get rid of the infection for good.
Eradicate those pesky bacteria.
But you got to do that while still making sure the fracture is stable enough to heal.
Can't forget about that bone.
And at the same time, you have to be ready to deal with any soft tissue problems that might need specialized coverage.
So many things to juggle.
It's a balancing act.
All right, let's talk treatment. What's our first line of attack for an acute infection that pops up within those first 2 weeks?
In those early cases, it's all about aggressive surgical debridement.
Getting in there and cleaning things up.
Yeah, you got to be thorough. You remove all that infected and dead tissue.
No half measures.
Then, if the implant is still stable, you usually try to keep it in place.
Give that bone some support.
And of course, you need to hit them with those antibiotics.
Guided by those culture results.
Always got to tailor the treatment.
Now, what about those chronic infections, the ones that show up after that 2-week window? Things get a bit trickier there, don't they?
Definitely. By that point, you've got a much higher chance of a mature biofilm having formed on that implant and in the surrounding tissues.
Biofilm strikes again.
It's a tough one to beat because it makes those antibiotics much less effective.
So we need to get more creative.
Yeah, chronic FRI often needs a staged approach with surgery and potentially a period of temporary stabilization. This deep dive is based on the OrthoMade's simple notes from website mokyingren.sg.
So what does that initial phase of managing a chronic infection look like?
Well, there are two main parts. You've got to optimize the patient medically, and then you do that first surgical debridement.
Two-pronged approach.
On the medical side, you've got to address any underlying risk factors that could get in the way of healing.
Things like diabetes that's not well controlled.
Smoking too.
Got to get them to quit.
And any peripheral vascular disease.
Those are all going to hinder the healing process.
Exactly.
Yeah.
And you've got to have that honest conversation with the patient about their options.
Sometimes those conversations are tough.
They really are. But in those severe cases, limb salvage might not be possible.
And then amputation becomes a part of the discussion.
Yeah, it's not an easy topic.
So after you've optimized the patient, then you move on to the first debridement. The notes talk about the 3+1 principle. What's that all about?
Right, the 3+1 principle. It's a great framework for tackling that initial debridement.
Give us the breakdown.
The 3 refers to the 3 main things you have to address. First, you completely eradicate that infection through really thorough debridement.
No bugs left behind.
Second, you deal with the bone itself, addressing any non-union or dead bone.
Got to make sure that bone is healthy.
And third, you got to make sure that fracture is stable.
Got to hold it all together.
Exactly. The +1, that's all about taking care of the soft tissues, making sure they're in good shape for healing and any future coverage procedures.
So making sure there's enough healthy tissue to work with.
Exactly. So during this first debridement, you're really going to town surgically. You're removing all that infected tissue, dead bone, and any unhealthy soft tissue until you see what's called the paprika sign.
Paprika sign. I've heard of that. What's that exactly?
It's when you see healthy pinpoint bleeding from the bone.
Ah, so it's a good sign.
Yeah, it means the bone has good blood supply.
Yeah.
And you want to see good, healthy bleeding in the soft tissues too.
So that's how you know you've got a clean slate.
You also need to check if that implant is still doing its job and whether it needs to come out at this point.
Sometimes you just have to say goodbye.
And in some cases, particularly with chronic infections, you might even shorten the bone a bit.
Why would you do that?
Well, it brings healthy, well-vascularized tissue closer together, which can help with healing.
Makes sense.
And you might have to do a fibular osteotomy at the same time to take some stress off the fibula.
So it's all about creating the best environment for healing.
Absolutely. Then you deal with any dead space that's left after the debridement.
Don't want any empty pockets in there.
You can fill it with antibiotic-loaded cement beads or threaded cement that delivers antibiotics right to the source.
Right to the battlefield.
And finally, you put on a temporary external fixator to stabilize the fracture.
Like a scaffolding.
And we use those negative pressure wound dressings to keep things clean and promote healing.
So that's the first surgical step. What happens after that initial debridement?
Well, you've got to keep a close eye on the patient. You're looking for those local signs of infection to go away.
Redness, swelling, pain.
All that good stuff. You're also monitoring those inflammatory markers with blood tests.
CRP, ESR.
Exactly.
Yeah.
And you keep doing those repeat debridements if you need to until those cultures come back negative.
You're chasing those negative cultures.
That's the goal. Once you're sure the infection is under control, then you can move on to the definitive surgery.
So the final stage.
This is where you focus on those 3 key principles. Again, taking care of any remaining bone defects, getting that fracture stabilized for the long haul, and making sure you have good soft tissue coverage.
Back to the basics.
Right. So for stabilization, you might consider exchange nailing using a circular external fixator, like an Lizaroff frame, or going with internal fixation using plates and screws.
So many options.
And if the soft tissue defects are really big and you can't close them directly,
then you bring in the plastic surgeons.
they're the masters of soft tissue.
They can do those fancy flap procedures.
They can work magic.
Now, what about a situation we might see on our exams? We've got an implant that seems stable and the fracture's healing nicely with callus formation on the x-rays, but there's still some evidence of infection, maybe low grade. How do we handle that?
If you've got radiographic proof that the bone is fused and that implant is solid, then you usually continue those antibiotics long-term to suppress that infection.
Keep those bugs at bay.
Until you get full bony union. Once that's confirmed on imaging, you can think about taking out the implant as a separate procedure.
So a delayed removal.
Exactly.
Now let's shift gears and talk about bone loss. Those notes mentioned critical bone defects.
But
what exactly are we talking about here, particularly for exam purposes?
basically, a critical bone defect is a chunk of missing bone that's not going to heal on its own without surgery.
It's just too big of a gap for the body to bridge naturally.
Exactly. There's no hard and fast rule about size, but generally, if it's bigger than 1 to 2 centimeters, especially if you've lost more than 50% of the bone's diameter all the way around,
That's when you know you're in trouble.
that's a critical defect.
So what tools do we have in our arsenal to deal with these critical bone defects after trauma and possible infection? This deep dive is based on the OrthoMade simple notes from website mokyingren.sg.
There are a bunch of techniques out there, but the 2 you absolutely need to know for your exams are the Masculette technique and the various bone transport techniques.
Those are the big guns.
Yeah, definitely.
Let's start with the Masculette technique. Can you walk us through the key steps?
So the Masculette technique is a 2-stage procedure. First stage, you do a really radical debridement, again, making sure you get that paprika sign.
Healthy bleeding bone.
Then you put in a special antibiotic spacer. It's made of polymethyl methacrylate, or PMMA, and it's loaded with antibiotics.
Like vancomycin and gentamicin.
The usual suspects.
And this spacer does a few really important things.
Right? First, it acts like a placeholder. It keeps that space open so scar tissue doesn't grow in and mess up your bone graft later.
Makes sense.
Second, it's like a little time-release capsule, delivering those antibiotics right where they're needed.
Continuous antibiotic therapy.
And third, it helps stabilize the fracture temporarily.
So it's multitasking.
You also need to stabilize the bone overall, usually with an external fixator or an antibiotic-coated nail.
Depends on the situation.
And you got to make sure those soft tissues are covered well. If you need to, you'll call in the plastic surgery team for a flap. That's stage 1. Then you wait about 6 to 8 weeks before the second stage.
Why the waiting period?
It gives everything time to heal up properly. Those flaps need to epithelialize,
So they integrate with the surrounding skin.
and the tissues around that bone defect need to get a good blood supply back.
Revascularization.
And during that time, a special membrane forms around that antibiotic spacer.
It's like the body's own little construction crew.
It's called the neomembrane, and it's packed with cells that can make new bone.
Pretty cool.
Plus, that waiting period gives you time to monitor those inflammatory markers and make sure that infection is truly gone.
So you're not rushing into the second stage.
Exactly. So in stage 2, you take out that antibiotic
We're
spacer
gonna say goodbye.
and you fill that bone defect with a bone graft, usually from the patient's own iliac crest.
Autologous bone graft, the gold standard.
You can also use an RIA system to get that bone graft.
RIA. What's that?
It stands for Reamer Irrigator Aspirator. It's a special tool that lets you harvest bone graft from inside the long bones, usually the femur.
So you're basically reaming out the bone marrow.
It's more than just a reamer. As it takes out that bone, it also cleans the canal with irrigation and sucks out all the debris.
So you get a really nice, clean bone graft.
Much better than traditional methods. And finally, you stabilize everything permanently, often with an antibiotic-coated nail if you can.
Sounds like a well-thought-out plan.
It's a proven technique.
Now let's talk about those bone transport techniques. The notes mention monofocal, bifocal, and trifocal. What's the difference?
Let's focus on bifocal bone transport, also known as distraction osteogenesis, or the Ilizarov technique.
That's the one we're most likely to see on our exams, right?
It's great for dealing with those larger bone defects, especially when you've had to do a lot of debridement because of infection.
So when there's a lot of missing bone,
You start by doing a thorough debridement, like with the Mascolet technique.
gotta get rid of all that infected stuff.
Then you put on a special external fixator that attaches to the bone on either side of the defect.
Like a bridge over the gap.
Exactly. Then you make a controlled cut in the bone called a corticotomy. It's not a full fracture, just a cut through the outer layer.
So you're weakening the bone in a specific spot.
You do this in a healthy part of the bone away from the infection.
Gotta keep it clean.
First, you adjust the frame to bring the limb back to its normal length. Then after the corticotomy, you wait for a week or two.
Giving that bone a chance to start healing.
Yeah, you want some callus to form at that corticotomy site. Then comes the fun part, distraction.
This is where you actually start moving the bone.
You adjust that external fixator every day, usually by about 1 millimeter.
Tiny movements.
But it adds up. You're gradually pulling the bone apart at that corticotomy site and essentially transporting a healthy segment of bone across that defect.
It's like growing new bone.
You keep doing this until that transported bone reaches the other side and docks with the bone over there.
Like two spaceships coming together.
The docking and consolidation phase, where those two pieces fuse, takes about twice as long as the distraction phase.
And you often need to add some extra bone graft to help it along.
It's a slow and steady process.
The notes mention something called the External Fixation Index, or EFI, and the Consolidation Index, or CI. What do those mean?
Good question. The EFI tells you how long the patient needs to be in that external fixator for every centimeter of new bone you've created.
Longer the bone defect, longer they're in the frame.
Basically. And the CI tells you how long it takes for that new bone to become strong and solid.
So it's a measure of bone healing efficiency.
You're right. The classic EFI for traditional lengthening with an external fixator is about 1.23 months per centimeter. But there's this cool technique where you do the lengthening over a nail that's already been put in.
So you're adding internal support.
It can actually speed up both the EFI and the CI.
Now, what about those other bone transport techniques, acute shortening and lengthening, or ASL and trifocal lengthening? When would you use those? This deep dive is based on the Ortho-Made Simple Notes from website mokyingren.sg.
ASL is when you initially shorten the limb at the fracture site to help close up the soft tissues or get that infection under control. Then, once things are looking better, you gradually lengthen it with an external fixator.
So it's like a two-step process.
In trifocal lengthening uses 2 corticotomy sites. So you're transporting bone from both ends towards the middle.
It's like a double teaming approach.
It's good for those really big defects or when you've got anatomical challenges.
Okay, so with all these different techniques, Mascolet-Ilizarov, acute shortening, what are the pros and cons for each one? That's something we need to know for our exams.
Definitely. The Mascolet technique has some big advantages. You don't need to adjust it all the time, and you don't have to worry about those tricky docking site problems you can get with bone transport.
Sounds good.
But it's not perfect. You can't fix those bad angular or rotational deformities, and you need to take a bone graft, which means another surgery and potential complications at the donor site.
Plus, you can't put weight on it right away.
Now, the Ilizarov technique is super versatile. It can fix both length and those angular or rotational problems, and you can often start weight-bearing early,
Yeah.
but it's more technically demanding, and there's a higher risk of complications at that docking site.
Like non-union or refracture.
And it requires a lot of patient compliance with those adjustments and pin care.
Not for everyone.
Then you've got acute shortening. It gets rid of those docking site issues because you're compressing the bone. It's stable right away and has a lower risk of non-union. But it's really only good for small defects, less than 3 centimeters or so.
So it has its limitations.
And there's strut grafting,
Right.
which is really challenging technically. You need those microsurgical skills to make it work.
Not for the faint of heart.
So in general, acute shortening is for those smaller defects less than 3 centimeters. Mass split and bone transport are good for up to around 5 centimeters. And if you've got something bigger than that, bone transport is usually the way to go.
Makes sense.
And one more thing about distraction osteogenesis. The bone formation that happens there is mostly through intramembranous ossification.
So it's different from how long bones grow normally.
Right.
And with all this knowledge, you'll be ready to tackle those challenging trauma cases. This deep dive has been based on the OrthoMade Simple Notes from website mokyingren.sg.
Absolutely.
So as you continue to study, think about this. We're seeing more and more complex trauma cases these days, and we're learning more about how biofilm plays a role in surgical site infections. How can we use that knowledge to prevent these problems in the first place?
Yeah, that's the million-dollar question.
How can we combine those preventative strategies with the treatment algorithms we've talked about today to get the best outcomes for our patients and reduce the burden of FRI and bone loss?
Food for thought.
It's something to keep in mind as you dive deeper into this fascinating field. This deep dive has been based on the OrthoMade Simple Notes from website mokyingren.sg.